to Respiratory Disorders Part 4. We're going to discuss upper airway issues. Common upper airway issues that occur in children include allergic rhinitis as well as the upper respiratory infection. Allergic rhinitis is exposure to allergens that create symptoms. The nasal discharge is clear and very thin. Because there's a lot of drainage, when the children lay down during the night to sleep, there's a lot of cough from postnasal drip. This is not an infectious process, so therefore they do not have a fever. However, they do have increased risk of sinusitis, and that can create a febrile illness. On the next slide, I'm going to show you what shiners, the nasal salute, and we might see nasal creases. They may have headaches because of the congestion in the sinuses, and because they have the postnasal drip, they have poor sleep and they're chronically fatigued. Now we'll compare that to the upper respiratory infection, which actually is an infection, but it's viral. Therefore, no antibiotics are needed. And it will be part of your job to convince the parents that when the doctor or nurse practitioner discharge them without a prescription, that this is the correct management. With a URI, the nasal discharge starts out clear, and then it becomes cloudy. They may or may not have sore throat. They may or may not have a fever. They also have a risk of developing sinusitis if we can't clear the nasal passages. Decongestants are no longer a part of the management for children. There's too many side effects, and it isn't worth it. But what we do for a URI is promote fluids to keep the mucus clear, and we can thin out the secretions in the nose by using nasal saline. So the child on the left has what we call the allergic shiners. It's that chronic darkening, and sometimes it's erythematous underneath the eyes from allergies. If you look at his sclera, it also looks red. So this child has not only nasal allergies, but it's also affecting his eyes. And the child on the right is doing that nasal salute, just taking that hand at the tip of the nose and pushing up because it helps stop the dripping, and it also decreases the itching in the nose. When they do that repeatedly, they'll get a little crease right on their nose, and you can sort of see where this girl has the bend in the tip of the nose, and so she's going to have the little nasal crease. Do we need diagnostic tests for allergic rhinitis or an upper respiratory? What is appropriate? Do we need to do a chest x-ray? Are nasal swabs appropriate? What blood tests would we need? Most of the time, we don't need any of these. If a child comes in with a lot of upper respiratory symptoms and now is beginning to cough and has become febrile, most likely the URI has become complicated. And we would anticipate this occurring in children who have risk. So they're immunosuppressed for some reason, or they're a special needs child who isn't up and moving around very much. Also, our little babies might be at risk for this. Allergic rhinitis, generally, we don't do much in the way of testing other than to do allergy tests. And these can be done through blood, or we do the scratch test on their back. For allergic rhinitis, we also want to promote fluids to keep the secretions thin. The best thing to do for allergic rhinitis is figure out what's this kid allergic to and avoid the triggers. So if it's things like dust, they need to have their room dusted frequently because they spend more time in their bedroom than they spend anywhere else in the household. They shouldn't be around the vacuum. They should use HEPA filters, that sort of thing. They can also use short and long-acting antihistamines, and so Claritin or Allegra is better than Benadryl because Benadryl causes them to be tired. But do keep in mind the pharmacology that sometimes children react the opposite of what we expect. You give them Benadryl, and instead of them being tired, they're bouncing off the walls. And it's a trial and error. We'll give it to the child and see how they react. When they become older, we can use the variety of nasal steroids, and this is something that you might be administering in the hospital. Remember, kids can come in with another problem and have this as another diagnosis. They just bring their chronic things with them. For an upper respiratory infection, promote fluids. Ask the parents to elevate the head of the bed. I always tell them to stuff a pillow between the mattress and the box spring, because if they only sleep up on pillows, these kids tend to fall down. In the hospital, just crank the beds up so that they're up about 30 degrees. If they have a fever, which is a temperature greater than 100.5, we can administer acetaminophen or ibuprofen. Humidify the air with either a humidifier in the room or have them stand in a hot, steamy bathroom. And then, of course, promote hand hygiene, because these kids are touching their nose, they're coughing, and they're going to spread it to everyone else. Now, infants are a little different with the URI. Why are they at increased risk? Their airways. What is different about them? What is different about their immune system? I'm not going to answer these questions. You are going to answer these in class. When infants have a URI, why are they more likely to be hospitalized? So the nursing interventions when they are admitted is we're going to do suctioning. Now, we do not have them in the skills lab, but you will see them in the hospital. We have a mushroom-tipped catheter for suctioning, and these are fabulous for suctioning out the nose. And you just put that tip up against the nair and then hook it to wall suction. Do one nair, let them catch their breath, and then do the other nair. We can also use some nasal saline if they have a lot of crusting of the mucus in the nose. So we'll use the saline, let it thin out, and then you will suction. Now, feeding can be very difficult because they can't breathe out of their nose and they're taking a bottle. So it's going to be a long time that you're going to be feeding this child. Sometimes we'll put them on clear liquids because the milk and the mucus don't mix very well, and then they start vomiting. So we'll just watch and see what kind of a diet is ordered. And then if you find that the baby is not tolerating milk and is vomiting, then you need to let the physician know so the order can be changed to diet as tolerated. So it's abbreviated DAT, diet as tolerated. If they're not tolerating milk, then we're going to go down to some liquids. If they are not maintaining their O2 sats, they're going to be on low dose oxygen. It's really hard to get that oxygen in when they have a lot of mucus in their nose. So you want to watch that cannula that it isn't getting completely obstructed from mucus. So this ends the lecture on upper airway problems in children.